hypothyroid, people who are truly hypothyroid, we also want to ask, well, what about people who are just sluggish thyroid? Will treatment of those individuals with that TSH, let's say of 3, 4, 5, 6, will they benefit from thyroid hormone treatment? Hi everyone, welcome back. Today let's discuss sluggish thyroid, how to define this in terms of your lab values, and if this is something that if treated can help you. And I want to start by just calling out the fact that in conversations online regarding healthcare, there is clearly a novelty bias. There's all these rewards for educators discussing how things can help you. And this is good, and we want to do this. We want to put every potential therapeutic option to help you on the table. Yes, 100%. However, we also want to have a filter so that if something cannot help you, you understand that, because the more effort you exert in the wrong direction, the longer it will take you to cross the finish line toward the goal that you have, presumably of resolving your symptoms. So we're always wanting to weigh these things and not just fall into the novelty bias of here's another thing you could do without any filter to assess efficacy. Just as a quick primer, you've probably heard this, but thyroid function, thyroid hormone is important because every cell of your body has a thyroid hormone receptor, and the thyroid hormone stimulation dictates cellular metabolism and therefore can affect the function of cells, therefore organs, and because of this can affect a wide array of systems and lead to a number of symptoms. So like many things, problems with thyroid have a very non-specific list of symptoms that it may cause. So this makes it challenging to assess, but there is good news. We do have ways to accurately appraise this. Also, as one sort of remark, or maybe a rough heuristic, if you will, to orient us, I think that conventional medicine has some things here right and some things here wrong, and perspectives from alternative functional natural medicine are in some cases correct, in other cases incorrect. And what I'd like to attempt to walk you through today is taking the best, the most accurate from each one of these camps. And let's then start by defining what is sluggish thyroid. And really another way of framing this is if you're not optimal, you're sluggish. And I've put together a table for you here, but I'll also narrate in case you're just listening to this. The conventional lab range for TSH, and TSH is really what I want to focus us in on. T3, as an aside, doesn't tell you about thyroid gland function. T3 is almost always secondary to something else: inflammation, stress, caloric consumption, carb consumption, gastrointestinal conversion, right? So T3 doesn't tell us about thyroid function. T4 to some extent does, but it's probably less important. The most powerful dictator of thyroid gland hormone output will be TSH. Now that's controversial, but we'll walk you through some literature today that hopefully helps you to see that TSH really does help us dictate and be able to appraise, are you normal thyroid? Are you sluggish or subclinical hypothyroid? Or are you true hypothyroid? So the TSH values according to the conventional lab ranges, which also correlate with conventional medicine parameters, are, again, TSH of 0.45 to 4.5. Now, the optimal is to be between 0.5 to 2.5. Estimations of exactly what the optimal is, they vary slightly from guru to guru or perspective from a certain group to others, but you're generally going to see that the optimal or the proclaimed optimal TSH should be below 2 or 2.5. And a common way in which this conversation regarding sluggish or suboptimal thyroid may manifest is depicted in this quote: Mary Sue, you have a TSH of 4. While this is within the normal range, it isn't optimal. This is likely the cause of your fatigue and brain fog. I believe once we get the TSH into the optimal range, you'll feel better. So let's examine this, because if this is true and correct, this opens up a lot of therapeutic potential for people with sluggish thyroid. However, if it's not correct, then this is a medication that you don't need to go on. And also really important because oftentimes when people start thyroid hormone medication, it is assumed to be lifelong. So we want to make sure to get this right. Where does this optimal range for the TSH come from, right? The TSH being below 2 or 2.5. Predominantly, it comes from the American Thyroid Association, and to quote their position statement, in most patients on thyroxine, so thyroid hormone, replacement, the goal TSH level is between 0.5 to 2.5. Okay, so it's a well-recognized and credible body in endocrinology, and this is their position statement. So one of the things that I wanted to go through was fact-checking this, because hopefully, if you've been following my work for a while, you have come or become accustomed to the fact that I'm open-minded on the one hand and always looking for new therapies that can help people. But it has been a very helpful exercise to fact-check certain positions, because some positions are based upon kind of shoddy evidence and other positions are based upon good evidence. And in other positions, there's not really much evidence. So it's the best hypothesis that can be mustered based upon the available evidence. So in this case, let's examine the question, does treating hypothyroidism to a TSH of under 2.5 improve thyroid symptoms? Because this is what we care about. We care about the correlation between the treatment and your symptoms. You don't want to fall into, and I include myself in this, treating of a number and then saying, well, okay, my numbers are normal, but I don't feel any differently. I want the therapies that have a high correlation between the lab value or the change in the lab value and me feeling better. So thankfully, there have been some studies that have looked at this. So this first study attempted to answer the question, does degree of hypothyroid treatment, meaning progressively more hormone being administered, improve symptoms? Observational study, 194 patients. And here's what they found. After levothyroxine treatment, 77% of symptoms improved and 23% of symptoms remained. But here's the key point I want to draw your attention to, and I'm quoting, there was no significant difference in the symptoms between the cases with TSH under 2.5 versus TSH over 2.5. So at least this one data point did not find agreement with the American Thyroid Association's position that one should be treated until their TSH goes below 2.5. However, this is an observational study and it's not very large. So we kept digging, and thankfully there are 2 randomized control trials, one in 50 patients and one in 138 patients. Also looking to appraise the hypothesis, will treatment of the TSH to below 2.5 lead to better improvements than those who are treated to below the normal range, which is below 4.5. And I'll just paraphrase for you here, but essentially, again, these 2 randomized control trials did not find that further treatment to get the TSH below 2.5 led to any improvement in symptoms. So taken collectively, we're starting to see a trend in the data, or the preponderance of the data, showing that this more aggressive treatment of the TSH down to below 2.5 does not seem to lead to better symptomatic improvement. But there's another question here we also have to ask, because we just examined that if people who are hypothyroid are more aggressively treated, will that improve their symptoms? Okay. But there's another question we can ask, because that's looking at hypothyroid, people who are truly hypothyroid. We also want to ask, well, what about people who are just sluggish thyroid? Will treatment of those individuals with that TSH, let's say of 3, 4, 5, 6, will they benefit from thyroid hormone treatment? Because who knows? maybe they will. And we have a really compelling data point to answer this question, a meta-analysis of 21 clinical trials looking at 2,192 patients. And again, these were individuals with subclinical hypothyroidism. This is the medical way of saying sluggish thyroid. It's where the TSH is creeping up to A4, A5, A6, A7, but it hasn't gone so high so as to be true, frank hypothyroidism. So, large cohort, sluggish thyroid, given placebo or levothyroxine. Why the placebo matters, and I'll tie this in again in a moment, but with almost any therapy, even therapies that have been adequately shown to be ineffective, there are people who will say, that therapy helped me. Now, I always reserve a time and a place for an exception, right? But it's crucially important to understand that placebo has a massive impact on subjective and even in some cases objective markers. And this can be a good thing, meaning if there's a cheap placebo that helps someone feel better, I'm all for it. But lifelong hormone replacement therapy should not be used, or at least logically, we would not want to use that if there was no true benefit and the only reported benefit was due to the positive expectation, aka the placebo effect. So this is why studies like this that take a large group, over 2,000 people with sluggish thyroid, half get a sugar pill, they don't know it's a sugar pill, and the other half get thyroid hormone, they don't know it's thyroid hormone, and then they compare the level of benefit. Because if everyone improves, then the therapy wasn't helpful. If only those getting the hormone improve, then the therapy was helpful. So this reconciles the fact that almost any, even the worst snake oil, will have some people saying, yeah, it helped me. And they found, and I'll quote, the use of thyroid hormone therapy was not associated with improvements in general quality of life or thyroid-related symptoms. These findings do not support the routine use of thyroid hormone therapy in adults with subclinical hypothyroidism. And another follow-up paper examining the same thing in 2022, I'll quote again, generally, treatment is not necessary unless the TSH exceeds 7 to 10. Keep that number in mind. In double-blinded randomized controlled trials, treatment does not improve symptoms or cognitive function if the TSH is less than 10. So the line of demarcation seems to be when the TSH goes above 10, almost everyone will benefit from treatment. We could maybe draw that line somewhere between the value of TSH at 7 to 10, but it's really this level when your TSH exceeds 7 to 10, definitely 10, that thyroid hormone medication seems to confer a benefit. And the schematic here I want to point you to, and again, I'll narrate for those just listening to this, is something I've mentioned on the podcast now for years, which is a natural and normal age-associated increase in TSH, meaning someone who's in their teens will have a lower TSH naturally, normally. Someone in their 20s, 30s will have a little bit higher, 30s, 40s, 50s, a little bit higher yet still. And when you get to elderly, 65 or older, then a TSH of 7 may actually be normal. And so this matters because we have to offset how we interpret the TSH based upon someone's age, right? So if someone is 55 and they have a TSH of 5 or 6, again, they are most likely not going to benefit from thyroid hormone medication. And these are high quality data points, review papers and systematic reviews, meta-analyses, which are looking at many, many clinical trials. So important to keep that in mind. Like I've said before, meta-analyses are akin to a truth serum because by nature, they are antithetical to cherry picking due to the fact that they summarize most of a body of data. Now, two potential counter positions or counter arguments come up, I think at this point, which would be fair, is the lack of treatment effect due to the type of thyroid hormone used, meaning using just levothyroxine T4 as compared to using T4 plus T3 in a combination formula, whether it be desiccated or a combination of levothyroxine with let's say, liothyronine, what have you, cytomel. And I think that's a fair question. However, my read on this is when people are truly hypothyroid, they do benefit from any type of thyroid hormone. However, up to 50% of people, and estimates here vary from none to as high as 50%, may actually feel best when given a combination hormone. So we have to delineate between the fact that people who are hypothyroid improve from any hormone, and some may feel best on combination, but that doesn't mean that those with sluggish thyroid who don't benefit from levothyroxine will all of a sudden benefit from combination hormone. I don't know that we have an ironclad sort of data to defend that statement, but I think that is the best interpretation based upon the data that we currently have. And also it's clearly reflective of our clinical experience, of which I'll share 2 papers that we published with you a little later. The second question, or the second sort of rebuttal, I feel or felt better once I started or was starting on thyroid hormone for my sluggish thyroid. Let me say, as one response to this, in the clinic, we have this sort of dictum of your body is boss. And it's very important to listen to an individual, because in many cases, symptoms are the most valuable barometer that we have to determine if what we're doing therapeutically is helping or it's not. This doesn't apply to all things because symptoms aren't always reliable, as you're starting to see some of the evidence here show that even those with an average TSH of 54 did not have different symptoms than healthy controls. So on the one hand, we do want to listen to the individual. On the other, we should bear in mind what I outlined a moment ago, which is the placebo effect. So the placebo effect may be why some of these people report feeling better. And another thing to bear in mind is oftentimes in integrative medicine, people will have a multimodal therapeutic intervention. They will change their diet, they will start using dietary supplements, and they will go on a hormone. So it can be very difficult to parse out, well, which one of these was actually driving the benefit. So all things to keep in mind, because ultimately the most important bedrock principle is that you do the things that will advance you towards your goal, and you not spin your wheels in things that sound promising but may not help you. And that's the balance that we're always trying to strike. So we want to now ask this question of, because there's a few sort of sub questions that umbrella, or that are underneath this larger umbrella question. Are symptoms caused by sluggish thyroid? And we examined that symptoms are not a reliable predictor of hypothyroidism, but what about symptoms and subclinical hypothyroidism? And there is merit to this question. There was one study published about a year ago, and they found, this is totally tangential, but it just makes the point, that there was actually more symptoms in individuals who had a high number of what's known as RDIs, respiratory distress events, while sleeping, as compared to those who had higher AHIs or elevated AHIs. This is the apnea-hypopnea index. The apnea-hypopnea index is what diagnoses sleep apnea. And the thinking is that sleep apnea will be the most correlated to symptoms. And this sort of tangential marker that may have an impact, but we're not really sure, the RDIs, the respiratory distress events, have less of an impact on how someone is feeling. But this one study found people with high RDIs but normal AHI actually had more symptoms. So there are times and cases for which the less severe condition might actually have more symptomatic manifestations. So we want to look at this question also. We want to look at the symptom correlation to hypothyroidism and the symptom correlation to subclinical or sluggish hypothyroid. So let's look at this. This case control study looked at 140 hypothyroid versus 560 control. So we're going to look at hypothyroid data and we're going to look at sluggish thyroid data. So starting with hypothyroid data, what they found was that symptoms were not a reliable predictor of hypothyroidism. And this was actually quite surprising to me. And this point here, I want to flag for you also. Look at this. 70% of controls, so healthy subjects, normal thyroid, reported one or more symptoms associated with hypothyroidism. So this is really important to bear in mind. And this is one sort of, contradiction to part of the philosophy that we embody at the clinic, which is your body is boss and we want to listen to your symptoms. And like I've said before, that holds very well in the realm of functional GI or digestive care, but it doesn't hold everywhere, right? And this is one example of where symptoms may not be a highly reliable barometer. So even though this is sort of our default position, there are exceptions to this we need to be aware of, hypothyroidism being one. So just to make sure I tie this in this study, the average level of TSH in those who are hypothyroid was 54. That is high. To impress upon you the difference between the Mary Sue analogy that we opened with, where her TSH was 4, that's sluggish, right? And we discussed the data looking at this cutoff of about 10. But when people are true hypothyroid, they are often true hypothyroid. And so what you see here is the hypothyroid cohort was 54. And the euthyroid cohort, normal thyroid, had an average TSH of 1.24. Also, look at the TPO. Another sort of tangential, sorry here if I'm going a little bit off the main topic, but TSH, we have been trying to champion the one paper from Tehran that found when your TPO antibody levels are over 500, that's when there's a correlation to progression to hypothyroidism. However, when they are below 500, the risk was minimal to non-existent that the TPO antibodies would then lead you to become hypothyroid. And you see that sort of embodied here, that the hypothyroid patients had an average TPO of 4,558. So just a few important things to keep in mind. Now let's look at subclinical, right? Does subclinical or sluggish hypothyroid correlate with symptoms? And this study looked at 376 patients. It was a survey study, so there are definitely some limitations to this, but it's one of the few data points that really tried to parse the difference between these groups. And we need this data because we can't just keep conjecturing. We have to start putting some of this stuff, some of these theories under the lens of analysis. And I'll just quote from their paper, patients with a thyroid function test suggesting subclinical hypothyroidism do not experience thyroid disease-related symptoms more often than euthyroid subjects. And here's the key point that gives us some direction. In subclinical hypothyroidism, aka sluggish, clinicians should focus on concomitant diseases rather than expecting symptomatic relief following levothyroxine substitution or the use of thyroid hormone medication. Concomitant diseases. I don't love the term diseases in research papers. They often use kind of pathological language, but what they're drawing your attention to is the symptoms are probably coming from somewhere else. And this is what we've been trying to champion both in the clinic and on the podcast for years now. And it's nice to see that our clinical observations are starting to have the research catch up with them. This begs the natural question, what concomitant diseases might be causing your symptoms? And one is digestive function. You've probably heard the pervasive impact that digestive function and the microbiota has on health. So to contextualize this survey of 73,000 individuals found a prevalence of 40% for FGDs, functional gastrointestinal disorders. This is sort of an umbrella term that encapsulates constipation, diarrhea, IBS, reflux, dyspepsia, heartburn, belching, right? So we could say a very general gut symptoms label can be assigned to as much as 40% of the population. And if this is a concomitant condition or symptom or disease that drives the thyroid symptoms, this is something for us to cue in on. And from the American College of Gastroenterology, they have found a prevalence of IBS, irritable bowel syndrome, of 10 to 15% of the population. So this is significant. Bear this in mind because true hypothyroidism is about 0.3% of the population. And if you include true hypothyroidism plus sluggish or subclinical, that's about 4.5% of the population. So it's something. But these gastrointestinal disorders or syndromes are far more common. And if they can cause thyroid symptoms, then we really want to pay attention to these. And this is hence our paper that our group published in 2022 in the journal Nutrients. And to quote, hypothyroid symptoms can also be from poor GI health. For example, IBS has been associated with fatigue, worse quality of life, depression, anxiety, and sleep disturbances. SIBO has also been associated with both depression and anxiety. So it's really important to bear in mind that you could have fatigue, depression, and insomnia, and that may not be coming from the thyroid. So especially if you have those symptoms, plus you have any sort of digestive symptom, this should start flagging suspicion that those concomitant issues might be driving the symptoms that were thought to be thyroid. And this is from a paper we published earlier in the year in 2022 in Integrative Medicine, a clinician's journal. It's a case series where one of the cases that was led by Dr. Joe Mather at our office was a beautiful portrayal of how no manipulation of thyroid hormone medication led to symptom resolution. There was the use of Levo, then Synthroid, I think plus Cytomel, then Armour, then NP. So from medication to medication to medication, really trying to dial in earnest, the thyroid hormone levels or the combination of different hormone types, T4 plus T3, and there was never any responsiveness symptomatically until there was a pivot to GI care. And in that case, just simple levothyroxine plus GI care led to normalization of the TSH and resolution of all the symptoms. And so this is sort of what we've codified, that GI dysfunction can cause thyroid symptoms. GI dysfunction is perhaps 15 times more common than hypothyroidism. Hypothyroidism can be incorrectly and overly diagnosed, especially if you're told that your sluggish thyroid is hypothyroid. That's an incorrect conflation. GI care can resolve thyroid symptoms, key point. And also another key point, GI care can reduce the required thyroid dose and improve thyroid function due to improved absorption and conversion. Other concomitant issues that you may want to consider, and these are common: undereating, eating too low carb, and or fear of food. And this typically occurs when someone is very well studied, when they've read a lot, when they've listened or watched a fair amount of symposiums or lectures on thyroid health. They can start to aggregate together all these food restrictions: gluten-free, grain-free, dairy-free, soy-free, goitrogen-free, and they're inadvertently forging an unhealthy relationship with food, and therefore, secondary to that, they are under-eating either calories, carbs, or both. And this can tie in with poor sleep. One of the first things that you will see go south when someone is undernourished, either calorically or from a carbohydrate perspective, is poor sleep. And this can then these two can kind of compound together, where the thinking is, well, it must be food that's causing my problems. Let me restrict my foods even more. Their sleep gets worse. They feel even worse yet still, and they get into this sort of snowball effect or this sort of self-feeding cycle. A lack of time outside, too much stress. these things have appreciable impacts on sleep and on mood, as just two examples, and on energy levels. So we can't discount the importance of these. Lack of exercise, not enough or too much. In fact, you may have recently heard my story where I overtrained, I burned out, and one of the things that happened to me was insomnia. I would fall asleep and then 30 minutes later kind of wake up and feel in a stress response. Like I couldn't go back to sleep. And even though I was kind of tired during the day, I was wired at night when I should be sleeping. And I thought, hey, maybe I have hyperthyroidism. Maybe that's what's sort of jacking up my system. No, I was overtraining. So we want to be careful to be attentive to exercise. And another one that's fairly insidious is female hormone imbalances. There are so many cases of this. And this is why I discussed as sort of a side chapter in Healthy Gut, Healthy You, even though the main focus of that book was gut health, I felt compelled to tie in the fact that things like cycle irregularity, PMS, depending on how old you are, hot flashes, and potentially exacerbations of gastrointestinal symptoms pre-menstruation or during menstruation. These are all very important. Also, mood kind of goes underneath the umbrella of PMS, I suppose, but it's really important to just mention that there are simple herbal interventions that can improve female hormone symptoms. Also, things like meditation and exercise have been shown to improve female hormone symptoms. And if you are coming back up to the top of our list here, if you are forging this unhealthy relationship with food, being too low calorie or too low carb will definitely perturb a female's hormones. And same thing with a man, right? If you starve a man, either calorically or carb wise, you can see poor sleep, you can see low libido. Same thing happens in women, just with a different sort of cast of symptoms. So these are all very important things to keep in mind. And remember, as we zoom out and sort of frame what we've discussed thus far, the hypothesis that treating sluggish thyroid will help you has pretty good data demonstrating that this will not improve your symptoms. But we want to both give you the, okay, don't go down this road on the one hand, but then what road should you traverse on the other? And here is a short list of things along with your gut health that you want to consider, and I would highly advise prioritizing over the treatment of sluggish thyroid. Of course, you must check all of these things with your doctor or your healthcare provider, but also bear in mind, like I've said so many times now, that you may be working with someone for whom you want to seek a second opinion from someone else. If you feel like you're being railroaded into this sluggish thyroid treatment, or maybe they're doing it in an open-minded fashion, but you're just not seeing any traction, that is where I would consider getting a second opinion so that you can get the care that you need and see the symptomatic improvements that you're looking to obtain. So in summary, to tie all this together, hopefully, thyroid hormone is important for cellular metabolism. Sluggish thyroid ranges come from thyroid medication treatment goals and don't appear to apply to those who are not hypothyroid. And even those goals of being below 2 or 2.5 with the TSH, as we outlined, don't seem to vector any better symptomatic resolution than getting someone to below 4.5. A surprising one for me, symptoms aren't helpful to diagnose overt or sluggish hypothyroidism. A TSH of over 7 to 10 appears to be where someone will benefit from thyroid hormone treatment. Look to other systems of the body to determine the cause of your symptoms if your TSH is below 7 to 10. Also, one thing I just want to underscore here, that this sluggish thyroid or subclinical hypothyroid, that this mild elevation of TSH, over 50% of these cases will spontaneously go back to normal with no therapy at all. You can increase the odds of that normalization with 200 micrograms of selenium and 83 milligrams of myo-inositol per day. And I may have that flopped. Double check me on that. Typically 200 micrograms of selenium is what's used. The dosages change a little bit when combined with myo-inositol. However, the point there to take away is the combination of myo-inositol and selenium have been shown to help you go from over 50% chance of normalization of TSH to an even higher likelihood. So all the more reason not to start on a hormone, A, because these will remit spontaneously over 50% of the time. B, you can improve the likelihood with supplementation with myo-inositol and selenium. And then C, the data have not demonstrated that giving these individuals hormone is helpful. Again, always check in with your doctor on this, but these are the data that you should be aware of so as to make informed decisions. And I just want to make sure to close with these 2 points. Again, sort of in reiteration, true hypothyroidism is somewhat rare, 0.3% of the population. Technically, if you take the average from 3 different NHANES data sets, it averages to 0.29, but we'll say 0.3 just for ease of conversation. So it is something, but it can be overly diagnosed when the diagnostic criteria that are used are kind of sloppy. And this is another point we've covered on the podcast in the past. I just wanted to reiterate that a recent meta-analysis found that 37% of people who are on medication could stop, feel fine, and maintain normal thyroid hormone levels. And there was another earlier study. So the meta-analysis found 37%. One small study in Greece by Levados found that 61% of people could stop their thyroid hormone. They had no change in symptoms, and they maintained normal levels of blood thyroid hormone. So this helps sort of tie together the fact that the sluggish thyroid diagnosis might be given with too little care. People are going on hormone that will not benefit them and that they do not need. And as researchers are coming back around to check this, they're finding anywhere from 37 to 61% of people can stop their medication, see no change in their symptoms, and maintain normal blood levels of thyroid hormone, therefore not need to be on a hormone for the rest of their life. Again, do not change anything without first speaking with your doctor, but the odds are somewhat high that you may have some tweaking to do when you either check in with your current healthcare provider or look to obtain a second opinion. So that, I suppose, is the long short regarding sluggish thyroid. This is something that my opinion has really evolved on over the years. And again, kind of tying in with what I mentioned earlier, I'm always looking for ways to help people, but there is clearly this novelty bias that leads to sort of a smattering of different hypotheses with very little pressure to determine which one of these hypotheses is not helpful. And it really makes me feel bad for the healthcare consumer because, and also for me sometimes, right, it's harder to take the position of don't do that thing because people want to hear about what they can or should do. This same thing happens with journal publications. There is a bias toward therapies that show benefit. And usually what you see is sort of this arc where when there's a new therapy, there's only papers published or really accepted for publication that show a favorable impact. And then over time, the journals start accepting the negative finding papers. And so you see the sort of effect size be more favorable and then sort of correct over time. The same thing happens with consumers in terms of YouTube or the blogosphere, in that there's a bias toward all the things that you should do, but there's not enough discussion about, well, what shouldn't you do or when might you want to avoid a given therapeutic. And so in this case, true hypothyroidism clearly seems to benefit people when they're treated with thyroid hormone. But the sluggish or the subclinical hypothyroid, thankfully we have ample data to answer this question, and there's just not a signal of it benefiting people, especially when we control for confounding changes that were occurring at the same time and for a placebo effect. So hopefully this helps you navigate what can be kind of a confusing landscape. If you're struggling with symptoms, I'm with you in terms of wanting to improve as quickly as you can. So let's offer up the things that can move the needle and be careful, again, not to spin our wheels with the things that may not have benefit or may not have merit. So again, my bottom line suggestion would be if you're truly hypothyroid, that's the time to consider hormone. If you're sluggish or AKA subclinical, again, it's actually kind of cause for celebration in that those will go back to normal in most cases, and those do not require or benefit from treatment. Again, make sure to check in with your doctor before changing anything, but these are the best data that we have to help answer the question, what is sluggish thyroid and what do we do about it? Okay, I hope that helps. I'll talk to you next time, guys.